give all the tips in this 6-7 minutes. I'll just run you through some situations which we have collected over the course of so many years. This is a patient who had two different patients who had unusual reaction. And the prime aim here is to differentiate between sterile versus infection. And I'll show you what we did. I loaded these patients with steroids by all the routes, topical, in fact, intravenous also I gave. And this was the result that this patient had at the end. So moral of this story was that when in doubt about tasks, and follow this patient very closely. In fact, this patient was in the OPD for the whole day. This was another patient referred for vitrectomy, but what changed my mind against vitrectomy was this whitish color lens droppings, which I thought, although there was limbus to limbus corneal edema here, again treated only with steroids, no interval antibiotics, patient did recover good vision. So when when the scales tilt towards TAS, you should load the patient with steroids. In contrast to this patient who has all the telltale signs of endophthalmitis, immediate interval antibiotic injection. And most of us are still persisting with Vanco and Cefta, but I think sensitivity of Kefta is decreasing, and I think more newer antibiotics are being tried in gram-negative organisms. This chart, I think, still useful to prevent dilution errors. It should stuck to the wall in the operation theater. Always you need to decompress with the help of vitreous biopsy. That's the best. Otherwise, I don't advocate vitreous aspiration at all, but this has negative consequences on the base of the vitreous. And topical treatment also, you see, we do persist as corneal ulcer patients get concentrated cefazolin, concentrated tobacin, and cycloplegic drops. So this was that patient which I showed, a 73-year-old gentleman. After one interval injection, this did recover good vision at the end of 3 weeks. But everybody may not be so lucky that you may have a partial response, or the culture sensitivity report may come by that time. Normally, I do not like to repeat intravitreal injections if the patient has not responded, unless the culture sensitivity report reports the other way around. Or if there is a heavy load, something like this, unlikely to respond to intravitreal. So in situation number 3, like this, or situation number 4, directly prepare the patient for MIVS, because in today's era, this has yielded good results. And whenever we eye enter into, say, the vitreous cavity, I do not do a half-hearted job, always do a complete radical vitrectomy, even at the cost of creating a posterior hyaloid PHF detachment also. But before we go inside, we always have to clear the anterior chamber, primarily because if you don't do that, this is one of the biggest tip, that you use an AC maintainer, take care of the fibrin in the anterior chamber with a separate stab incision after you have injected visco also to protect the endothelium. After this has come out, this membrane over the surface of IOL, then only you go inside and do a definitive job. Because if you don't do that, it's very difficult to do a precise job in the vitreous cavity. In situation like this, where there is no limbus to enter, so what we prefer generally is to do a pars plana approach for clearance of the anterior chamber. And the way we do it is that from the pars plana, after you have this 6 minute cannula straight entry, no angled entry, from the pars plana we make a hole in the iris, and after you have made the hole in the iris, then with the help of various instruments, you can tease away all these exudates over the surface of IOL, over the surface of iris also, and then go inside and do a depression vitrectomy. This does help in a lot of these patients who have chamber full of exudates and we can't enter the chamber also. Other thing is question or trap is whether we should remove IOL or not. In a mild endophthalmitis, no, but in patients who have very severe endophthalmitis, like I showed before, or a recurrent kind of, or fungal, we generally end up removing the IOL. And this is one patient who had presented with corneal abscess, and this was the lady who had already received multiple injections, and she presented with corneal abscess, and we did this entry. First principle always to clear fibrin from the anterior chamber and remove all this muck over the surface of IOL. Also sever all the connections between the abscess and the intraocular cavity. And in this patient, we ended up removing the IUL, and this IUL had one haptic which was missing, meaning there was eventful surgery at that time. Now the pupillary area is aphakic. You become more bold and remove away all the exudates, do suturing also, and do a depression vitrectomy. And at the end of it, I injected oil in this particular patient. And this was the result of this patient at the end of 4 weeks, oil still inside, but BCVA 624 at that time. Fungal endophthalmitis generally is a diagnosis after we make, is a diagnosis of after we fail with the first injection. And although we have, voriconazole and other Zole derivatives, most of these patients end up with vitrectomy and revitrectomy. This patient already had multiple vitrectomies, and still there was recurrence after a couple of months. The only thing which we did was because it was already a vitrectomized eye, we peeled off the hyaloid face because there are colonies always collecting behind the hyaloid. So this made us believe that you should try and remove hyaloid also, because sometimes you can have exudates behind the hyaloid also. So you can't do a core vitrectomy and come out in all the patients. This was the result of one of the fungal proven endophthalmitis after oil removal. P. acne endophthalmitis, again, you see that plaque over the surface of posterior capsule. Or in such patients, there are 3 situations. Sometimes in the bag, vanco will help, as helped in this patient. In the bag, vancomycin, because intravitreal vancomycin may not reach inside the bag. This patient had a vitrectomy done, but we didn't remove the IUL, and fortunately recovered good vision after 6 to 7 weeks. In this patient who was a medical professional, and ultimately we ended up removing the IUL because although the vitreous part was not so difficult, but more difficult was to remove this IUL and all the bag itself, because that took actually more time. Once we removed the IUL by mobilizing this, each and every bit of the capsule, because pupil was not very big, so you have to use the suction part, tease the capsule bag in front, and that took a lot of time in removing the entire bag. And ultimately, once this entire bag, we still went inside, did a total complete vitrectomy, wanted to be sure that we have done a radical vitrectomy. And that ultimately led to a remission. She did not have much recurrences. Once the cornea gets involved, you have to take help from cornea colleague. And in this situation, this was where we used a temporary keratoprosthesis. Because all this melt is taken care of, the keratoprosthesis is fitted, and then you enter into a vitreous cavity, do a total complete vitrectomy, and then after that, you fit in the graft. So these were a couple of situations which I thought I'll share with you, and some tips of vitrectomy. These are the 10 tips which I wrote down a couple of months back. That suspect, react, differentiate from TAS. When in doubt, have a peer review, prompt injection, and regular daily review, in fact. Pay attention to culture report, early vitrectomy. Don't delay vitrectomy too much, otherwise things may become irreversible. And refer always to a higher center and document, because this will save you in the court of law. Thank you very much for your kind attention.
Thank you, sir. I think the last slide summarizes the entire thing with giving the most important 10 tips for management of endophthalmitis. But since we would be having a lot of anterior segment surgeons also sitting here in the hall, before they refer a patient for management to a retina surgeon, would you advocate that they give the intravitreal themselves?
So this is a fairly frequent situation with us, and all credit goes to them. In fact, one recent patient I had operated in Delhi itself. So I told, you give intravitreal injection. So they gave, but the patient responded to that. I didn't do anything. In fact, I just followed up the patient, and patient today is 612. So all anterior segment surgeons should know that art and trick of giving injections, because the only thing which hurts is they will give a Avastin or Lucentis, but they sometimes will hesitate to give antibiotics. But in this particular patient, believe me, Manisha, the patient responded because that surgeon did a good job.
So I think that is a game changer if you give an intravitreal on time.
I think all of us have to propagate and make them feel confident that they can give it.
No, certain times the low-grade endophthalmitis, which is appears very fine and very little endophthalmitis that has more recurrences actually. The staph epidermidis and P. acne, those things require almost 4-step approach, where you showed the last step, that removal of all the bag and IOL, but short of that, intra-bag injection of antibiotic can also be done as a trial. Actually, there is a good study about this, and
so
in that,
Dr. Ajit, I did show that. I don't think so you saw that. I showed 3 patients. In one patient, in the bag antibiotic did help, but in the third patient, it did not. She already received in the bag injection 2-3 times in Agra and then was referred. So first patient of mine, P. acne, it did respond to in the bag vancomycin. That is the first step.
Yeah. It's a 4-step procedure, so that need to be explained to the patient. Otherwise, certain times if we seeing mild endophthalmitis and good prognosis, it probably may not work in the clinic. Thank you, and we will